Okay, today I thought I'll talk about breast infections. Now, they're very common and quite often, mismanaged and too much of antibiotics and not the appropriate step taken at the right time. So these are all things that we should avoid. There are three main, you can group these breast infections into three main areas. One is infection associated with lactation, and one is breast infections that we talked a little about it yesterday, periductal mastitis, and because of inspissated secretions getting infected. And the third one is granulomatous infections. So these three, most infections would fit under these three criteria. Of course, sometimes you may have a not sebaceous cyst which gets infected in and around the breast, and those are all different, but most of the infections will fall into one of these categories. One is infections that are associated with lactation, and infections that are associated infections that are associated with ductectasia and inspissated secretions, and three granulomatous mastitis. So all three are fairly common. So we'll just go one by one. So lactation associated infections can occur anytime during lactation, more often in the early period, in the first few months. When the mother is learning to breastfeed, the baby is learning to latch on, and what used to be natural earlier has now become something that has to be taught. There are specialists now called lactational consultants who train the mother about how to feed the baby. So, but it still doesn't prevent infections. So what happens, sometimes there is cracked nipples, inverted nipples, retained secretions. Breast milk is the ideal culture medium. And also babies tend to harbor Staph Aureus in the nasopharynx. And most of these infections, particularly if it occurs early, is due to hospital-acquired infections, and it's in our own data, over 60% of the lactational infections that we see are MRSA associated, and these are very tough to treat, and early recognition is very important. So these are some of the reasons. So before it actually forms an abscess cavity, there is more pain, redness, and inflammation, like any typical third-year medical school progression of inflammation. It starts off with some mastitis. You may not actually find any localizing signs to say that it is an abscess, but sort of diffuse pain, redness, and particularly after completing breastfeeding, mother notices that sharp pain after completing. So she feeds the baby. While when it initiates the feed, it's painful, and then after suckling, when the baby finishes feeding, then there is one sharp pain, and these are all usually indicative of some infection. And at this point in time, ultrasound may not show any localizing signs like an abscess cavity. There may be a little skin edema and surrounding increased echogenicity in the breast tissue, but it may not actually show any cavity. So treat them with appropriate anti-inflammatory and sometimes early start of antibiotics. So most common infection here is Staph Aureus, and the Staph Aureus responds very well to flucloxacillin or augmentin. Flucloxacillin is simpler to use, but some people may not be compliant with it. It has to be taken 4 times a day. If they're not compliant, and then it just drags on. So augmentin is twice a day. It might be easier for the woman to be compliant with. And this is a situation where you need to see them more frequently, and don't hesitate to do frequent ultrasounds. It's not like that one-off procedure. So when you see early, there may not be much signs, but if you recognize and treat with antibiotics early enough, it may abort itself and recover. But sometimes if it's past this stage, then it forms cavities. It forms abscess cavities. So even if you have a normal ultrasound, ask her to come back in a day or two again to review clinically as well as do an ultrasound. So if there is a suggestion of an abscess formation, then you can deal with it quickly rather than letting it form a bigger abscess cavity, destroying more breast tissue. So that is important. So if you see, this is a normal ultrasound. So you see that classical appearance. This is the skin and subcutaneous tissue. This is the pre-mammary zone where you have, it is mostly a layer of fat. And this is the fat plane that you go when you do a mastectomy. And this is the pre-mammary zone. This is the mammary zone. You can see how the echogenicity varies. The fat is isoechoic, they're set at a sort of medium gray. This gray you will get used to as you keep doing it and as you keep seeing more images. And this bright tissue here is the fibroglandular tissue. Fibroglandular tissue is very echogenic and you get bright tissue here. And this is the retromammary fat. And so if you see, this is a normal breast appearance. But when there is mastitis, you can see this skin becomes slightly thicker. Can you see that? And it is slightly thicker. And then you also see that there is the lymphatic channels under the subcutaneous tissue. They're all slightly prominent. And you see they're all like inflamed, and this subcutaneous fat is also more echogenic here when compared to this side. So this is how a mastitis looks without an abscess cavity. This is how a mastitis looks, and there's not much difference between the breast tissue here and the fat, because it's all like filled with because of inflammation. So when it is a mastitis like this, when you see it on ultrasound, clinically, obviously, you'll find a little bit of edema, a bit of redness. Patient will have obviously all the signs of acute inflammation along with pain and heaviness. So this is the right time to start antibiotics, and then don't leave it for review after 1 week. This is a lady we have to see more frequently. So ask her to come after a day or two, sometimes 24 hours the next day itself or the second day. So and then you see whether this is resolving or building up to a bigger cavity. So if you a few days later, it may actually form a cavity like this, and it is mixed echogenic because obviously pus is thicker, and there is some Brownian movement, and it is quite echogenic, and so this needs. So classically, when we all did 25-30 years back, when I did my surgical training, it was always IND, under anesthesia, and you have to break open all the locules and put a drain, counter drain, and stitch it. Otherwise, like it forms an antibioma, and antibiomas are difficult to distinguish, and all sorts of things we used to learn. I don't know whether Bailey Love still gives all these things, but now we do not recommend IND at all, because the reasons, the difficulty with IND, one, it separates the baby from the mother, it requires hospitalization even if it's a daycare procedure, it requires anesthesia, and then you leave behind an opened wound, which is very difficult to challenging for the entire family to keep dressing every day or every alternate day, and it takes almost a month to heal, and when it heals, it leaves behind a puckered, ugly scar in the breast. And this counter drain and things and all are not required at all. So what we instead do is ultrasound-guided aspiration. So this is very simple to do. It is a it's not like liver in a cavity, which you need great expertise to do. Here it is a superficial surface organ, and very, very simple to do. Put a probe and you see this cavity, give some local anesthetic. Use a wide bore needle. Quite often people make the mistake of aspirating with their usual 18 gauge needle. The pus is very thick, and sometimes it will not drain through that. That debris will get blocked the needle, and you may not be able to aspirate, and then you call it failed aspiration and go and operate, which is not required at all. Use wide bore needle, those pink, not the 14 or a 16 gauge needle. If necessary, use a bigger Venflon, the orange Venflon. And if you use a Venflon, you can always add a 3-way tap also. So if the cavity is big and it's very echogenic, then you can use the 3-way tap and flush from one end with about 10 ml of normal saline. So as you keep flushing, you keep aspirating it, and that actually decompresses the whole abscess cavity. And this can be very well done under local anesthetic. A lot of reassurance. The patient obviously will be very anxious, so a lot of talking to and a lot of reassurance. Sometimes when the pus is very close to the skin, then a mini IND will help. Rather than trying to put a needle there, just give that local and use your 11 blade to make a nick under that local anesthesia. And then if you just put a little pressure, all of the pus will come out and it's simpler. So always, always, always send the pus for culture and sensitivity. We do not want to miss the MRSA associated infection, because fluclox and augmentin will not treat MRSA infections. So if it is non-MRSA Staphylococcus aureus, it responds well to flucloxin or augmentin. But if culture usually takes about 48 hours. So why don't start linezolid straight away? We have only one precious oral antibiotic for MRSA infections. We abuse it in the community level, then someday we will not be able, even that will become resistant to linezolid. So linezolid should be used only in culture proven MRSA. Otherwise, it should not be used in other infections. So what I do is, when I aspirate, I start them with augmentin first and then ask them to come. And this is one thing, the report which I follow up, I don't leave the patient to follow up the result. This is one thing that we take the initiative and follow up with the microbiology lab to get the culture reports, because this is a prescription we have to give as soon as possible if it's documented MRSA. So you follow up with the microbiology lab. If it is MRSA positive, then call the patient, either see her or whatever means of communication you have, prescribe linezolid. So this 600 milligrams twice daily, that helps. So, and sometimes this aspiration has to be done many times, and it is still worth to keep doing aspiration rather than IND, because every time you just put a needle that is either 14 gauge or 16 gauge. So, and tell the patient warn them in the first time itself when they come, that this may require another cup aspiration, sometimes more than one, because while the antibiotics works, it may recollect again, and we do the same thing, put local anesthesia and aspirate any number of times. I've aspirated even 5-6 times. So it is a trade-off. If you tell them that otherwise this requires surgery, hospitalization, wounds to dress, and scarring, they will easily opt the aspiration method. So we have to counsel them adequately and keep bringing them back every 2 days. And one other thing is, we see a lot of lactation associated infections. Every time we aspirate, we actually we use only one room. We have 2-3 rooms in the clinic where patients are seen, but for infections we do not actually use the machine and the room for other procedures, because we do a lot of surgical dressings, cross infections, and we don't want surgical wounds to get infected. These are all things that we have to implement, particularly in wherever possible, in private practice, everywhere for that matter, but because you don't want to risk your get surgical infections. So we make it a point to work on in the room after we finish the clinic, because MRSA otherwise it becomes a very difficult thing to deal with in surgical patients. So it's not just enough if you aspirate, you actually treat that room, your machines, remove all the sheets, and particularly now that we are all aware of the corona issue, this we should do for every abscess that we see, particularly lactation associated abscesses, because these have a higher probability of having MRSA. So this is something which we do routinely in our clinic. So this, again, if you see, this is a typical abscess cavity. It's a irregular in appearance, and you may actually have some vascularity in the periphery. It's often mixed echogenic, and along with the clinical signs, it's very difficult to mistake it for anything else. So you again put a needle into it, all of this collapses and it comes out very freely. Sometimes if the debris blocks, just take 5 ml or 10 ml of saline, push a little bit inside the if you don't have a 3-way tap, and then aspirate again, so that clear, or put another needle again, whichever that helps you best. Do it under generous local anesthesia. So 99% of the abscesses can be treated this way. In so many years, I have probably taken 2 or 3 patients to theatre and to do an IND. But otherwise, most of these are done as local procedure. So this was supposed to be a video, but unfortunately the source video is not there, so it will not play. So if it is the next question is, can I continue feeding? So if it is a peripheral abscess, not around the nipple areola, then obviously it is ideal for the woman to continue feeding. But if the abscess is closer to the nipple areola complex, it may be difficult for the baby to latch on and continue breastfeeding. So she can empty that, because empty that breast, use a breast pump and empty that breast and use the other breast for feeding. And once this infection resolves, then she can feed from both sides. If you want to suppress lactation, then use cabergoline 0.5 milligrams twice a day. And remember, when cabergoline is used, it should not be any suckling. So if the baby continues to suck when cabergoline is used, then the suckling reflex will actually promote more breast milk in spite of your cabergoline. So no emptying with breast pumps or no feeding. So it's given, and then use a lot of ice packs and anti-inflammatory, and it takes about 2 to 3 days for it to work, for breast milk to stop. I usually wait for some time before we advocate this, because when there is infection and you give cabergoline immediately and she's not able to express the milk out, that stagnates and the infection actually gets worse before the infection gets controlled. So I usually wait for some days before we resort to this option. And so, as I said, if the abscess is very close to the skin, then you will know on ultrasound. So if you see this abscess, there is a little bit of a distance between the abscess cavity and the skin, whereas here, if you see, this is just very close to the skin. And here it is much quicker for you to, you can aspirate here also, but here if you just give a particular small local anesthetic and a small nick, just 11 blade nick, and then the whole thing comes out without you having to struggle, and no need to put any drain or anything. And if it call back, the secret here is to call back frequently, every alternate day, to review this. Even if she doesn't want to come, you just have to tell her that, one culture results might be different, too. If it reaccumulates, if you treat it early, then the infection does not destroy. Remember, whenever the infection happens and abscess cavity happens, it's because one of the accumulated milk getting infected, too, it also destroys the surrounding breast tissue. So the whole thing becomes necrotic. So before repeated such episodes happen, you can treat it preemptively. So periductal mastitis, like I said earlier, I don't know if I'm going to be repetitive for people who were not able to attend yesterday. It will be useful. So normally the ducts, the terminal ducts, there are about 8 to 10 or 15 ducts that open into the nipple. And these ducts measure about 1 millimeter to 2. When a woman is lactating, that duct increases in diameter. It can go up to even 4-5 centimeters. So in a non-lactating woman, it's usually very thin, about 1 to 2 millimeters. This duct towards the end, closer to the nipple areola tissue, is lined by a myoepithelial layer, because you need that myoepithelial layer for some contractility, because when milk has to be ejected, there has to be some contractility. And this myoepithelial layer over a period of time disappears with age around the menopausal age group. And when it does so, the ducts actually dilate. And when they dilate, what should be about a millimeter or two becomes 3 or 4 millimeters. The secretions that are normally produced accumulates and gets inspissated. These and the water in it gets absorbed, and then the muck, actually the debris, gets accumulated. And this is an ideal culture medium for infection, particularly in diabetics and smokers. And remember, nipple is a nipple openings are again infection can enter through the nipple openings into the duct system. And again here, unlike lactational infections, which is usually Staphylococcus aureus, here you get both mixed infections, both aerobic and anaerobic. And so these infections are typically around the periareolar area, and you may actually have a range of symptoms like thickening, edema, pain, and you may have those little small abscess cavities, sometimes bigger abscess cavities, and they may be diabetics, and it's often recurrent. It keeps happening again and again. And so this is I showed this yesterday, but again just to show how much a duct can dilate. So this is the dilatation either due lactational duct. Woman is lactating. Again, these are normal ducts. This physiological changes. When a woman is lactating, it may dilate like this. Sometimes a woman who's on antipsychotic medication, tricyclic antidepressants, and some of these antipsychotic medication, as a side effect, they may have ductal dilatation. There again, it can be, so if the duct walls are smooth, there's nothing growing within it. It's just a physiological dilatation, dilated duct with accumulated secretions. And then a cross section, it looks like this. So this, how do you differentiate a growth within a duct to inspissated secretion? When there is secretion, there's there is a layer of fluid around those inspissated the secretion. It's not, you see, it is not attached to the duct wall. This is the longitudinal view, and this is the cross section of the duct, and you see that it is clearly within the lumen, not attached to the wall of the duct. So then the reason why this periductal mastitis happens is this with time, with prolonged inspissation happening in the ducts, some of this content leaks from the ducts into the surrounding tissue, and this incites inflammation. And usually it's an inflammation in plasma cell infiltrates are dense there, and it forms erythema and induration around the NAC. So long standing, if it keeps happening again and again, what happens, it incites so much of fibrosis, and it causes shortening of the ducts. Because of the fibrosis, it pulls the nipple inwards, and there may be nipple retraction. This nipple retraction is very different from, I couldn't bring out a picture. It is there somewhere in one of the PPTs, but I don't know, it's not there. So it is a very typical retraction. In malignancy, if you see, the retraction is more or less uniform, the entire nipple sinks in. But here it is like a postbox, letterbox nipple. The nipple, there will be like a transverse line, the way it is pulling in. Like you have a letterbox, those days you had that letterbox where you post, there's in the post box you have a rectangular slit through which you post your letters, something like that. This is typical, it's called as a split-like retraction. This is very typical of because when people keep having recurrent erythema, induration around the NAC, and there is, because of long-standing infections, repeated infections and fibrosis, the whole thing, when you feel it may be very hard, and differential diagnosis with the cancer is very difficult. So particularly when it gives a history of nipple getting pulled in, then you would also biopsy it wherever there is a doubt. But clinically, it's nicer to use your clinical skills. And if you see a slit-like retraction, then you can be sure that it is not malignant, and it is usually related to periductal mastitis. So again, remember, this happens in the older age group, in the perimenopausal age group. So repeated infections. Once the infection settles down, she should have a mammogram and ultrasound, and where you cannot clearly differentiate it from a malignancy if it warrants it, then do a guided biopsy as well. So every time it happens, you need a broad spectrum antibiotic, augmentin, And sometimes when they have 3 or more episodes of infection in a year, they are fed up, you're fed up, then it is worth doing a total duct excision. So circumareolar incision, again the incision should not extend more than 50% of the circumference of the areola, and you don't use diathermy near the areolar end, because there is a higher possibility of having a areolar necrosis, skin necrosis. So use sharp scissors. Use an artery forceps to curve up the entire duct system behind the nipple, and transect it with the scissors, and then remove that button-like tissue just behind the areola and cauterize it well. So after this procedure, there may be a nipple retraction, because the support behind the nipple with the ducts that is lost, and sometimes the nipple actually sinks in, and you must warn the patient of this. And that actually takes care of repeated infection, because you are essentially discontinuing the ducts, and that should actually remove the problem of recurrent infections. And always, whatever we remove, we send it for pathology, and make sure that you're not missing a malignancy. So again, here, if there is pus, aspirate it or drain it with the mini IND in local. This need not be taken to theatre, just local, and drain it will suffice. And it's because it's mixed aerobic and anaerobic, augmentin works well. So like I said, recurrent episodes use do total duct excision. So this is one of those typical superficial periductal mastitis, not a very big cavity, small cavity closer to the skin again. So this you can aspirate it, or sometimes it's better to actually put a little 11-blade nick and just it empties completely then, and then appropriately. So the thing is, granulomatous mastitis, unfortunately, it was a different PPD, and I did not include. I'll just talk about it. I can show some case later, or I'll show now. Share screen. Is it visible? The new screen?
No, the laptop screen only has come. The PowerPoint has not come yet. You can log out, log in case. Oh yeah, it's there. Full screen. Make it full screen.
How much time do we have?
You have time, no problem. Today we are free till 12.
Oh, but I don't have much material anyway, so.
Yeah, you can have discussion in case.
Yeah. So this is a couple of case scenarios I put in here. This is somebody who's 32 with left breast pain, swelling and mass. Clinical finding, she came with left breast pain, but we actually found the swelling and mass on the right side. And age 58, I don't know if I've got the right PPT on. Sorry, there's some mix up here, but anyway, so this mammogram actually can if you notice in this mammogram, there is some asymmetry. Can you see that here? So the mammogram is usually, it's a paired organ. It should be symmetric on both sides, and when there is an asymmetry, particularly in the CC view, see, this is the outer quadrant and this is the inner quadrant. And here you see there is an asymmetry when compared to this side. This side it's relatively empty, but here there is some architectural distortion, some asymmetry on the right side. And the in real time you can actually see that there is some trabecular prominence, and adjacent there is some skin thickening here as well. So in the right breast inner quadrant. And here again, if you see, this is the MLO view, and look at the harmony here and here. There is something distinct definitely happening here. You do an ultrasound, you see there is patches of hypoechoic area with some edema. And if you put a Doppler there, there is some increased vascularity in the surrounding tissue. And if you see here, there is a diffuse tracking-like appearance. It is not one big cavity, but if you see that there is some changes in echogenicity here, some linear shadows, and it is very distorted here on ultrasound. And so this is actually typical of infection. And before it forms an abscess cavity, it may look like this. Sometimes a chronic, long-standing granulomatous infection, because granulomatous infections, unlike acute infections that are associated with periductal mastitis or lactation infections, they are acute infections. Whereas, as the word indicates, chronic granulomatous infections, the symptoms are disproportionate to the signs. She may not have much acute inflammatory signs, tenderness and pain. There might be some heaviness because of the edema and fluid accumulation in the breast, but the skin may not show redness. There may not be anything pointing, and that is why you're able to even do a mammogram. In an acute infection, you can't compress the breast. In a chronic infection, clinically you're not sure what is happening. There might be some heaviness and thickening in the breast, but no localizing signs. And obviously somebody who's 58, you would actually do a mammogram, and mammogram shows that, and ultrasound shows this. So if we see this, we know that this is likely to be inflammation. But again, the differential diagnosis here is lobular carcinoma. Lobular carcinomas are very difficult to diagnose, and sometimes can have pictures like this on ultrasound and asymmetry on mammogram. So something like this in a 58-year-old woman, I may not leave it to chance or trial of antibiotic treatment. What I will do is a biopsy. And let the histopathology confirm that it is not a malignancy and it is infection. So where there is a chronic granulomatous disease, again the diagnosis is by histopathology. Clinically, the signs may not be like acute inflammation, but when you actually do an ultrasound, you find tracking like this. So you do and then treat with I'll talk about treatment of granulomatous mastitis later. So here, this is a 31-year-old lactating. She has lump in the breast with pain. She's already treated with the course of antibiotics, and she came to us, and by the time she saw us, the abscess cavity was large, and it was almost, see this probe width, this is about 5 centimeters, and this is a trapezoid view to accommodate more lateral viewing. This could easily be a 7 to 8 centimeter abscess cavity. So this again, if you look at the axilla, this is axillary lymph node, and this is important to perceive this later when we talk about axillary lymph nodes in malignancy appearances on ultrasound. This is important to see this. So normally there is a cortex and a medulla. Medulla is fatty, cortex is hypoechoic. So hypoechoic cortex is usually uniformly thickened in inflammation. If the node is reactive or inflammatory, the entire node responds uniformly. So the cortex is uniformly thickened in infections and wherever there is any reactive lymphadenitis. Whereas if it is a malignancy, the cortex malignancy, the thickening is because of the deposition of tumor cells and the growth of tumor cells, and that may not happen uniformly, that may happen unevenly. So part of the cortex will be thickened more than the rest of the cortex, and sometimes the entire node becomes so diffusely metastatic that all of it obliterates even the medulla, and the entire thing becomes hypoechoic, and it actually pushes its way out, and it will be more globular than it is oval. So this is the node that is retained its shape, it's reniform in shape. You have a hilar area, you have a medulla, and then the cortex is there, and the cortex is uniformly thickened. So these are all radiological features that you should remember and try to correlate it with every patient that you see. So this is obviously inflammatory. And what we do, put a nice large bore needle and aspirate it, and once, so about 25 ml of thick pus was aspirated, And we talked about this earlier. The only thing that you have to remember always is not to miss an inflammatory carcinoma, particularly when you're seeing at that early stage the breast that is. I have seen one patient who was lactating who had an inflammatory carcinoma. So particularly in that early stage mastitis, where if there is no localization of pus, then you actually she comes with a little bit of redness and tenderness and pain. You put her on antibiotics, and if you don't bring her back and see, and if you don't have that higher level of suspicion, then this may get missed and we lose time. With inflammatory carcinoma, we don't like to lose time. So this is very important. Just keep that in the back of the mind. This is very uncommon, but it can happen. And as I have seen it once in my career. So keep that in mind. So this is another case, 27-year-old and left breast lump for 2 weeks. And if you, why did we do a mammogram? I don't know. So we saw something like this on ultrasound, and so when I see something like this, I'm always worried, particularly with vascularity like this. I'm always worried that it is a lobular carcinoma. And that it is a malignancy. So when I see something like this, I go and do a mammogram. So mammogram here, again, you see there is some asymmetry. Here, that is not visible on the other side. And here again, there's something happening here which is not quite visible on the other side on the CC view. So it is not a definite mass, it's more like an area of asymmetry. And you do a spot compression which kind of compresses directly on the mass. And if it is persistent on spot compression, and then you know that it is something, a significant pathology. And on this, we do a biopsy. And what does it say? It is a granulomatous infection. So granulomatous infection is not very common in very young people. It is more in the 30s and 40s. We do see it in the 20s also, but it's uncommon and very young people. And earlier, we used to treat them all with antituberculous treatment, because 5-6 years back, all of these things, you see granulomatous infection, and the first thing we do is start off on antituberculous treatment, because it's very difficult to differentiate between a granulomatous infection due to tuberculosis versus granulomatous infection that is idiopathic. And I must say that, you know, I would have treated at least around 100 patients with antituberculous treatment then, without any culture proof of tuberculous bacteria thing, just going by the clinical signs and the ultrasound appearance and histopathology saying it's granulomatous infection. Majority of them responded. And but now we have a regulatory, now the thinking has also changed. Now we realize that, you know, more and more of these patients have idiopathic granulomatous infection rather than tuberculous, and the treatment is very different. And also now there is a regulatory compliance that we have to deal with. Any prescription of antituberculous treatment, it has to be notified, and it can be penalized if you don't. So most of us now, at least I don't, unless there is a documented tubercular culture, which we've had on a few occasions. You know, you send, when you aspirate pus, you send that for culture sensitivity and AFB culture. And if AFB culture comes back as positive, that usually takes about 40 to 60 days for the results to come. Then these are patients that I refer to infectious diseases specialists rather than me prescribing antituberculous treatment. This is since the recent government regulation. And otherwise, right now what we do is, if we have granulomatous inflammation, then we send it for tuberculous culture. And infectious diseases specialists always ask us to do gene expert MTB And but we never had any significant contribution for any of these tests. Actually, I still do it because they ask us to, and because I don't treat it and they treat it, because they want this information. So therefore, whenever we aspirate, we send it for all this. We also do a core biopsy, not just aspirate and culture sensitivity. We also do a core biopsy to prove that it is granulomatous infection. And the pathologist, there are some distinguishing features on pathology, where lymphocytes and the epithelial cells from Langerhans type giant cells are more predominant in the tuberculous infection, whereas it is more granulomas, but not the Langerhans type of giant cells in the idiopathic granulomatous mastitis. So we quite often both granulomatous inflammation and due to tuberculosis and idiopathic granulomatous infection, you never find a positive culture. The culture usually there's a lot of pus cells but no bacteria grown. And then of late we're seeing more and more patients with Corynebacterium infection. These again look like granulomatous infection. And so the pathologists usually, the microbiologists usually give a report saying, and a secondary report will follow if subcultures show something. And then you call back the lab in a week's time again to check if they've grown Corynebacterium. So these days now I put it in the request also, culture for Corynebacterium group of bacteria. It will take more time than the usual 48 hours. And it is worth checking that, because if it's Corynebacterium type related granulomatous infection, then it's simpler to just treat with amoxicillin or ampicillin. It responds very well, and it may require antibiotic for a longer period, but usually resolves. So look for, when you have a granulomatous infection, one, keep a possibility of tuberculosis always in mind. Look at culture, and culture positive, then we have to treat with anti-tuberculous treatment. In the meanwhile, they can be on some anti-inflammatory drugs and aspirate as frequently as it is required. And then if it is Corynebacterium, treat with ampicillin or amoxicillin. So the natural history of granulomatous infection is that it keeps, it's like one of those autoimmune type responses. It keeps causing local destruction and abscess formation. So as it keeps forming, you ask the patient to come back to you. If there is a new pocket, you put a needle and aspirate. Keep aspirating. Surgical excision does not help. You excise, it will come back in another area close to it, or it forms sinuses which are very difficult to heal. So keep aspirating it as frequently as required. And the natural history itself is that in a period of over a period of 6 to 8 months, the whole thing resolves on its own without you doing anything, just aspirating it as it's required. And some long-term anti-inflammatory medication like indomethacin, given 25 milligrams orally over a period of 3 to 4 weeks will help. It will at least help symptomatically, and pain and heaviness will resolve. And it also helps in controlling the inflammatory process within. So where do we use steroids? And if you have a clear culture that says it is negative for AKT and negative for COX, then and it keeps forming recurrent pockets of pus, sterile pus that doesn't grow any bacteria, including COX, tuberculous culture or Corynebacterium. And these are patients who could have a trial of steroids. So start with oral prednisolone, about 40 milligrams, 2 weeks of 40, then keep tapering it, and call a couple of times in between to see how she's responding. And then when you wean off and stop steroids, then give another a course of indomethacin for some more time. This is non-steroidal. And over a period of about 2 to 2.5 months, this whole thing will settle down. If it recurs again, try another course of indomethacin. And so these things can, after treatment, it can come back again. It can come in the other breast, it can come in the same breast. It is a nuisance, but there is nothing much else to do except aspirate whenever required, and diligently use steroids and non-steroidal anti-inflammatory, and keep reassuring and talking to them. And the diagnosis is not clinical. Clinical plus imaging and biopsy. Biopsy should clearly say that it's granulomatous infection, and not you must rule out the malignancy, because these things tend to occur in a later age group, and sometimes lobular cancers typically mimics some of these findings on ultrasound and mammogram. And so therefore you do not want to miss a malignancy, and don't just go by your clinical and imaging findings, always get a histopathology. So I think we can discuss this. So this is one other similar case. 43, heaviness, discomfort in the breast, 2 months duration. There's no fever. There is a mass to feel with skin thickening. There are no signs of acute inflammation. So clinically, because of the age, we obviously suspect malignancy. Do a mammogram. If you see, this is a normal breast. You see how there is an asymmetry, and there is a kind of normal harmony here, which is lost because of some process happening here. And this is an MLO. You see how this normal breast looks, whereas this side is obviously asymmetry is there with some distortion in the breast tissue. And you do ultrasound, you see such a big abscess cavity, so all of the same breast. And then, like I said earlier, aspirate, and obviously these, if it is due to granulomatous mastitis, culture will not show anything. And AFB culture, it usually takes a longer time, and that also is negative. Then this is a patient who needs to get treated with antibiotics. And sometimes it looks like this. So there is no clear one big cavity. These are the ones that are difficult to aspirate, because if it forms one big cavity like that, it's easier to aspirate and it collapses. But here you will do still a diagnostic aspirate and diagnostic core biopsy. But here there is not much accumulated pus in one area to aspirate. It's like a diffuse tracking kind of, tracks that lead up to the skin and form sinuses. This is very typical of I've labeled it as TB. This was done much earlier, but this is how both tuberculous infections and granulomatous infections look like in the breast. So again, there is a mass visibly seen, and a mass, usually you have a circumscribed border seen in both the projections. And here, if you, this is a case for what we did yesterday or day before for fibroadenomas. So there's here you see a circumscribed mass, and when you do an ultrasound, again it's a circumscribed mass, but it's transfers in orientation, hypoechoic. But there are a lot of there's an angulation here. We don't like anything that angulates in masses, and there are more than 1 or 2 lobulations. And look at the vascularity; it's peripheral as well as central. And this is what we call as elastography, and there is some amount of hardness in it. So obviously this lump is suspicious. We did and the node here looks normal. This is the hilum and this is the medulla. The cortex is uniformly thick all around. So this we did a biopsy, and it turned out to be a fibroepithelial lesion with a very cellular stroma. Obviously this was benign, but this is a type of lesion where even if the pathologist says benign, we would go and remove it. And surgical excision is warranted because of the appearance. This is what we call as radiology pathology discordance. Considering her age and the appearance, even though the pathologist says it's benign, we still remove it, and removal also is confirmed that it's. So fibroadenomas need not always be classically benign in appearance. Complex fibroadenomas, about a third of them are difficult to distinguish it from malignant lesions. So this would be typically called like a Bayer's 4 B or C because of the angulation and the vascularity. So this Bayer's category definitely 4, and then 4 you have A, B, C, and I would actually be call it as C. And then biopsy comes as negative. I would still excise it and prove that it is negative. So I'll stop here. Any questions I can discuss?
Ma'am, hello, ma'am.
Yeah.
Hello.
Yes, yes.
Ma'am, is there any indication of surgical excision in case of recurrent tuberculosis of the breast?
No. See, that's why recurrent tuberculosis now there is a distinctly different thought. It's not like earlier before. I mean, I was treating all these infections with ATT for a very long time. So only about the last 4 or 5 years, this whole concept of idiopathic granulomatous mastitis came about more strongly. And we realized that 6 months of ATT with all those drugs is unwarranted. And so these days, the primary diagnosis, unless there is an AFP culture that is positive, do not treat with ATT. You send for regular cultures, ask for a cornybacterium culture specifically. That usually comes a week. It takes longer to culture, unlike the regular bacteria. This takes longer to culture. So you usually wait for a week or 10 days and ask the microbiologist again, is there some cornybacterium growing? And if it is so, treat that. That usually responds to simple antibiotics like amoxicillin or ampicillin and or doxycycline over a slightly longer period, and so 3 to 4 weeks of treatment. And so if that is negative, then you wait for your AFB culture. That usually takes 40 to 60 days. And that is negative, then start the patients on steroids. So in the meanwhile, the patient can have repeated aspirations and non-steroidal anti-inflammatory like indomethacin or whatever. That's the easiest drug to use. You can use that. So once
how should we?
culture is negative, then you use steroids.
Madam, what
Ma'am,
about
but sometimes-
antibioma, treatment of antibioma in the breast?
Again, antibioma is something it is overrated. So if it's like how scarring happens externally. If you're treating an abscess, if the abscess is aspirated completely, there might be some residual induration in the breast for a long time, and most of these things resolve on its own. And there might be a little fibrosis which persists, and over a period of time, maybe a couple of months or 3 months later, there may not be anything. Just like if you see a scar outside, you may actually feel a little bit of thickening, but other than that, there is nothing to be found. And this antibioma and antibiomas, difficult to differentiate with malignancy, all those is old time teaching.
But antibiotic, how long we have to continue antibiotic?
So most of the lactation associated MRSA infections would need at least 2 weeks of linezolid. And other patients, again, a week to 10 days of antibiotics. If it is granulomatous mastitis with due to cornybacterium infections, maybe longer, 3 to 4 weeks. Steroids over a period of two months. I believe me, I have seen this a lot, and over a period, I've never had to resort to surgery for these infections.
Thank you.
Ma'am, Manjula here. Morning. I have two questions, ma'am. In relation to lactational abscess, patients with abscesses situated more centrally, so when they're in a lot of pain, how do we advise them to empty the breast? Because using a breast pump would be very painful at that point in time.
No, actually, once you've aspirated and it's decompressed, and then that it becomes relatively comfortable for them, and you're not going to leave them long enough. You're going to this is why I keep saying, bring them back as frequently as required. Sometimes the very next day. So you keep emptying if it collects till you get the culture reports. And then before you put on the breast pump to empty, ice packs. So ask them to put ice packs over the nipple areola area, and then use the breast pump to empty, and that actually numbs it for a bit, and it is a bit more bearable. And then once your culture result comes and you treat with appropriate antibiotics, the whole thing, like, you must see the relief when they come back the next day. They'll all be smiling, and these are very, very grateful patients. They'll never forget you even years later. I often bump into some of them, here and there. I may not recognize them, but as you treated that abscess some 5 years ago, 10 years ago, very, very grateful patients they are.
Right, ma'am. Ma'am, the second question in relation to granulomatous mastitis, what is the role of immunomodulators?
Actually, that bit I leave it to if I find it difficult to manage, because we are mainly cancer surgeons, right? We don't want to get stuck with our role is to diagnose, our role is to treat those symptoms. If it requires aspiration, we do it better than the others, so we do. But other than that, if you start off with steroids, but if it is more challenging than that, I usually refer to infectious disease specialists, and they are the ones who are best with they know when to start immunomodulators. I haven't used them personally, so I I've resisted using steroids also, because we don't have the bandwidth to follow up and monitor side effects, and therefore I usually infectious disease specialist, and this is what they do. But sometimes if they're not accessible, or if you find that some patients it's easier if you just sort it out rather than sending to another person doing some more additional investigations. So you just want to just make it simpler for them, and I prescribe. But anything requiring more than that, it is better to be left with people who know what they're doing.
Okay, right. Thank you, ma'am.
Ma'am, how to treat multiple microabscesses in breast?
Again, what do you mean by multiple microabscesses? Is it acute, chronic? It has to come under the two headings, isn't it?
Yeah, it is acute. Like when we drain an abscess, surrounding we see a lot of edema and microabscesses.
Why I don't drain them at all? If you drain,
then it becomes a quite wide debridement if we drain all.
That is why don't drain them at all, because wide debridement ends up destroying a lot of breast tissue and leaves behind such a puckered, ugly scar in the breast that she'll remember you forever for that. So just
but if we don't drain, then they recur.
No, aspirate, culture, appropriate antibiotics, aspirate again if required. I have aspirated 5-6 times.
Okay, ma'am.
And the micro abscesses is just more extension of your breast abscess inflammation, isn't it?
Right.
So aspirate and you get a positive culture. So if it is a positive culture, it's bacterial infection. If it's a negative culture, then the process of grouping it under granulomatous mastitis comes. So it has to fit into one of these three criteria, isn't it? If it's an acute infection, what infection? So outliers are very rare in this area. Usually they fall into one of these groups. It's acute infection, Staph Aureus, methicillin resistant Staph Aureus, occasionally to treat appropriately and treat for an adequate duration of time. Call them in between every 2 days. Keep emptying the cavity. More aspirations if needed. This is still more economical than surgery. When you aspirate us in the clinic, it may, even in the most corporate or private centers, it may not be more than 2,000 or 3,000. But when you take them to for surgery, it may be 30 or 40,000, and then repeated dressings. And it is an unnecessary procedure for the patient. So even if you have to aspirate 5 times, it's still worth it. Take them back again and again for aspiration.
Dr. Selvi, good morning.
Good morning.
I'm Dr. Amarvani. I just have got few questions. Excellent lecture by you. Just wanted to ask you, rather than going for repeated aspirations, image-guided aspirations, can we go and put in a drain, image-guided drain, and then whenever it is blocked, can we flush or anything like that?
I guess it can be done, but it's very inconvenient for the patient, particularly a feeding mother, to have a drain there, and it's simpler for them to come and have it done. I guess it can be done. You can put like what they put in abdominal cavities, a pigtail, whatever can be left in, and then it continuously drains. Versus you aspirate it again, which both are, I guess it's okay. But no, I'm comfortable aspirating, so I do.
Okay. I think the most difficult cases are like non-lactational breast abscesses. To diagnose them properly and treat them and follow them is the most difficult things. In my clinical practice, I had seen non-tuberculous granulomatous diseases like sarcoidosis also, like initially coming with single lump, and then which has become multiple lumps and forming a sinus.
That would come under the granular sarcoidosis. All that will come under granulomatous infections.
Yeah, non-tuberculous granulomatous diseases. Yeah. I'm talking. Okay.
So it's very clear that it fits into one of these baskets. So in non-lactational infections, it's important to rule out a malignancy, because in most of the non-lactational infections, except in periductal mastitis, you do not have symptoms. The signs are disproportionate to symptoms. So there may be an abscess cavity, but she may not have acute pain like in an acute lactational abscess. So it may just have some little tenderness and heaviness. And when there may not be any redness like you would see with bacterial acute lactational infections. So the importance here, particularly in any chronic procedure, is to rule out a malignancy, because these things tend to happen in an older age group also. And in the pretext of calling it a granulomatous mastitis, we should not miss a malignancy. So I have a low threshold to biopsy in these patients. I'd rather do a biopsy and have a proof that it's granulomatous infections on HPE than assume clinically and miss a malignancy.
Yeah, the point the point you are telling is, I had a doubt in such cases, if there is a lump or in the ultrasound you feel that there is a inflammation, increased vascularity. I was about to ask you a question whether you go for FNAC or biopsy. Just now you answered it is biopsy, because the biopsy you have more tissue and the histopathology can tell us whether it is malignant or not. Even though this my question is not related to the present topic, I just wanted to ask you, suppose on ultrasound you find an intraductal papilloma, so how do you go about it?
Talked about it yesterday. So intraductal papilloma has to be excised. Some or more and more now there is some clear diagnosis of intraductal papilloma and not troubling the patient. It can be left alone, but most of us would actually prefer to excise. So depending on the location, and if it's a single duct, just and it's a young woman, try and remove only that portion. But if it's an older woman, then you may have to end up doing a total duct excision along with the removal of that duct which has the papilloma. Okay. We discussed
great. Thank you.
Extensively.
Thank you.
Yeah, Meghna, you want to ask a question?
Good morning, ma'am.
Morning, Meghna.
Ma'am, my question is, more often we have been asked in the exam that my diagnosis is a carcinoma breast. So they ask us why it is not chronic abscess or tuberculous mastitis or granulomatous mastitis. So how do we defend ourselves?
Sorry. Come again. I didn't get it.
Clinically, the differential diagnosis for carcinoma is granulomatous mastitis. Can that be offered as a differential diagnosis? If it's offered, how will you clinically differentiate between the two? Clinically.
So in this, that is why I said biopsy. So in that age group, 35, 40 plus, with 2 months or 3 months history, no acute signs, just some palpable mass, some skin thickening, and because any chronic inflammation, what can it do? Particularly if it is central in location, it can also produce some nipple retraction, it can produce some skin tethering, all of this can happen. So a lot of the signs overlap, both in clinical examination and on imaging also. If you do, I showed you a couple of mammograms, very difficult to distinguish it from a malignancy. So this is why, it has to be kept in mind. So unless the dictum is unless proven otherwise, it's a malignancy. So work your way backwards. Assume that it's malignancy. What will you do for a malignancy? You would actually, when you see a patient, you would do a triple assessment. So you do a mammogram, you do an ultrasound. And then triple assessment also includes histopathology. So put a needle into it, take a bit of tissue. Tissue comes back as granulomatous mastitis, and you deal with it as it is. Otherwise, it's malignant. So if you do that, you're unlikely to miss a diagnosis. So when they ask you the differentials, I often disagree with these examiners. They're not practical. It is a puzzle that you're trying to solve, and it is an algorithmic approach. And you can't keep arguing about this sign, that sign. As long as a clinician you have the awareness about both the possibilities, and this is the workup required to rule out, and they should be happy. But if I were an examiner, if you tell me both that they are possible and I would do this, I would actually give you an excellent mark.
Because I'm not an examiner. Yeah.
I've not taught in medical colleges. I've never been an examiner, but I do not like the system of for the exam you say this, for the exam you tell this, for the exam you do this. What you practice is what you should teach, and what you teach is what. There's nothing separate. A patient is not managed separately for the exam. Patient, in real time when you pass out and go and sit in the clinic, these are the things that you'll follow, and you cannot think for the exam I'll do that. You have to think what is practical. You have to answer that patient and you have to solve that. So this dichotomy between the exam and the patient is very, very unfortunate in our medical colleges.
Now my second question is, does tuberculosis of the breast, it has a classification and accordingly does it has a management?
So actually, earlier, like I said, we used to treat these all as tuberculosis, but now it's redundant. We need to have a culture positive. It's very, very, when you send it to the pathologist, they almost always do a Z-Nielsen. They mention that AFP negative. We also wait for, if there is pus, and obviously when you culture for routine bacterial cultures, you also get AFB culture done. If culture is positive, then again I would refer to an infectious disease specialist, but normally what they do is 6 months to 9 months of anti-tuberculous treatment with the combined drug regimen, four drugs to start with, and then after a couple of months, then 3 drugs or 2 drugs, whatever routine they follow. So this is very important, and only if you have a culture positive. Now, otherwise the government can question you. And if you give a prescription, your prescription can be traced back to you, and you have to notify it. So you have to notify that you're treating or given a prescription for TB for such and such a patient. So another infectious diseases, people are better equipped to do that than us. So I would actually, my job is to diagnose and hand it over to them. But this is what they'll do, 6 months of 8.
Yeah, Dr.
One more question.
Yeah, yes.
Ma'am, a word about management of retromammary abscess.
Retromammary abscess is, you mean like chest wall abscess?
Yes, ma'am.
So this is cold abscess, isn't it? And this is more likely to be, again, tuberculosis. So this, you always have an origin somewhere, like psoas abscess. Again, this is something that you should be imaging it and aspirate, because this again is possible to access it for aspiration, and the same protocol applies. Culture, look for other sites, screen for other sites of TB, chest X-ray, look at the axilla, there's significant nodes, because somewhere it has to track up and come there, and mediastinum. So check all that, and then again hand it over to infectious diseases people.
Thank you, ma'am.
Ma'am, while we aspirate this tubercular abscesses, do we need to do anti-gravity aspiration or something like that?
No, wherever it's more prominent. It has to be when you're not aspirating directly, you're aspirating under ultrasound guidance. So wherever the ultrasound shows the largest area and access, you don't want your needle to traverse a long distance. So wherever it's accessible.
Okay, ma'am, what do we do about galactosele? Do we need a biopsy in that case?
No, galactosele is again, there will be a typical history of breastfeeding. you end up seeing galactosele either during lactation or after lactation. After lactation, there is a residual area of milk collection. Galactosele is because the draining duct is walled off. It is either blocked or it has a blind end. So milk collects in that ductal system and forms a large cavity. Occasionally, this galactosele is filled with milk, and it can get infected. And over time, what happens is galactosele, the water in the milk, and it becomes more inspissated and thick and pasty-like. So during lactation, you put a probe there, you see a large fluid-filled area. So the thing is, you aspirate it, it just fill up the next day. Because if she continues to feed, milk produces there and it again collects. So aspirated is to reassure yourself and the patient that it is only a milk cavity. But then quite often, if she wants to feed, as long as it's not infected, most of these things are not painful and they just remain without causing much trouble. So you just reassure her and tell her to continue to breastfeed, and only if there is any pain or infection there, redness or acute pain, then ask her to come back. Otherwise, and then tell her that after she stops breastfeeding, a month later or a few weeks later, then you can empty that galactosele. If you leave it for too long, then it becomes very insulated, and then you can't drain it, because then it becomes like a paste and it may not drain. So after she stops lactation, in about 2 to 3 weeks, or a month, if she comes back to you, that time when you empty, then the lactation is stopped. So then it will not refill and it will settle down. So the galactosele, you don't need to operate, and no need to, and there is no contraindication for another pregnancy. Just warn her, if she can have another pregnancy, breastfeed, it may refill again. If it spills at that point, we'll deal with it again. When you aspirate, it's nice, clear milk.
Okay, ma'am. And ma'am, how do you differentiate acute mastitis from an inflammatory carcinoma?
It is a nightmare. So usually, that is why you give antibiotics and keep seeing them a couple of times. So if she responds to antibiotics, and all of this should settle down. If she does not respond, it continues to persist. And again, systemic signs will be there. If it is a infection, mastitis, there will be fever and pain. Whereas inflammatory carcinoma, the redness will be there, but the symptoms will be disproportionate to the redness. There may not be much acute pain or fever. And something that doesn't settle with appropriate antibiotics for a week or so, then that is a case where you would do a biopsy. A punch biopsy helps, because inflammatory carcinoma is diagnosed by tumor cell. Yes, so punch biopsy, including the skin, helps.
Okay, Dr. Aziz, you want to ask
Thank
something?
you so much, ma'am.
Dr. Aziz? Okay, then no more questions. I shall close the session for today.
Thank you.
Thank you so much.